basically, we can split up prosthodontic cases into a cosmetic needs section versus a functional needs section. But a lot of times these two components actually come together. So I would say most cases are actually cosmetic and functional, even if it's just something in the front. The various kind of procedures that we do in place, but it really kind of comes down to a few different things. Cosmetic, implant surgery, and also full mouth reconstruction. So actually trained, a lot of prosthodontists are trained in surgery as well, especially related to implants.
There's no acidic hydrogen.
Basically, each of those categories, I'm going to talk about the terminology first, and then we'll go into actually the cases related to them. I plan to do some bonus material at the end. Unfortunately, just the timing, there's so much to go over right now. I'm not going to be able to cover much of the full mouth reconstruction or that kind of bonus stuff, but I'm hoping that we can do another session someday in the future, and we'll talk about that stuff too. So when it comes to cosmetic terminology, there's a million different terms in prosthodontics, and there's actually glossaries out there that you can review. And so I'm just going to show you just kind of how big this glossary actually is. And new versions get released all the time because things in dentistry are constantly changing, especially nowadays with digital formatting. And so I can't obviously go over 100 pages worth of definitions, so presentation tonight. A restoration, anytime I say that, it means anything that replaces missing tooth structure. So it could be a part of a tooth, it could be the entire tooth, it could be multiple teeth, that's all considered a restoration. Anterior there's kind of two main definitions in dentistry. It's a position, so in front of or forward of, or it could also mean the front teeth, such as the incisors or the canines. Posterior is the opposite, so it means behind or backwards, or refers to the specific teeth, the premolars or the molars themselves. By the way, can YouTube still hear me okay, or any updates on that? Or
yeah, so everyone will be joining through the Zoom. Okay. The ones who are having trouble will join through the Zoom.
Okay, all right, that's fine. Okay, and then the last kind of restorative terminology I'll talk about is the word bonding, which is a technique involving adhesion of two different materials. Teeth tend to be hydrophilic, and things that we use in dentistry tend to be hydrophobic for the most part. So you have to have something in between them to kind of join them together. Okay, cosmetic terminology. Once again, a lot of different things that we can do for restorations. The two main categories are indirect versus direct restorations. Indirect means that we've sent it out somewhere outside of the mouth to make them. So usually that's a lab. Nowadays, you can actually do a lot of these in your own office with milling machines. So indirect means it's made outside the mouth. And that's things like veneers, crowns, bridges, inlays, and onlays. I don't have a lot of time once again, so I'm not gonna be able to talk about each of these, but you'll see a few of these as we go along. Direct restorations are things that are done in the mouth. The majority of them, such as silver fillings, composites, which are white fillings, and chairside veneers, which it's a form of composite also. Okay. There's a bunch of different crown materials out there, but I'm going to talk about the main ones. Lithium disilicate, which is also known as EMAC. This is probably the most popular nowadays. There's two different ways that these can be made. The images that you see here are milled. So a machine actually grinds these up and turns them into our digital design. So that block that you see at the bottom there is actually what they look like. They're like a giant piece of Lego that gets turned into the shape of a tooth. It's in a blue state at the beginning, which is actually a purple color. And then it gets fired in a furnace and it turns into the tooth color. Porcelain fused metal is another kind of, I would say this is a more traditional style crown. It's not used as often nowadays, but there's definitely reasons to use it in certain cases. There's metal on the undersurface, like a coping. At the very bottom, you can see there's a whole set of those. And then porcelain gets stacked on top of that. And then another extremely popular material is zirconia. And it's basically a white ceramic material. Zirconium on the periodic table is a metal, and then when you turn it into an oxide so this is actually zirconia, it's actually called zirconium dioxide. That's actually the chemical makeup of this. Once you do that, it becomes a ceramic. It's no longer a metal. And then the 3Y, 4Y, 5Y are the main categories. Y stands for yttrium. It's a component that's added to the zirconia to stabilize the strongest state, crystalline state, which is actually the cubic state. Normally cubic disappears at room temperature, so you have to stabilize this somehow. The more yttrium that you have, so when you got to like 5Y, it becomes more translucent and more beautiful, but it also becomes weaker. So 3Y zirconia is the strongest one. 5Y is the weakest one. And there's a whole set of numbers in between these three also. And then the fourth one, very traditional, is gold. It's not used as often today, but it's an amazing material for shaping around crowns, or sorry, for shaping around teeth. My cat keeps coming around. Okay, so I'm gonna get started with some of the actual cases now. Patient wanted to be able to smile again, and sometimes it's very difficult for patients to do that, and you'll see why. So I asked her to smile, and honestly, this is the first reaction she gave me. So when people do this, it's actually very common for a lot of patients. It's called a guarded smile, which means they're actually trying to protect themselves. Another way they do this is actually by raising their hand up over their mouth because they don't want to show their teeth. So when I asked her again to actually smile, this is kind of shows you a little bit about why she didn't want to smile too big. So I thanked her for smiling big. And then when we take a closer look at what's going on here, you can see that the incisal edges, so the chewing surfaces of the teeth, are very uneven. You can see that there's a lot of discoloration around these teeth in yellow. We're also looking at a crown that's very obviously a crown. We're also looking at the remains of a root that are still in the bone and the gum tissue there in the green. Coronal portion, or the crown portion of the natural tooth, in the white there. So very cosmetic related. Patient didn't want to smile, and so we go into the process of making teeth for her, which starts with an initial shade selection. Starting with, we go into the preparation for crowns. You can see that she had some fillings in place. White line is actually the outline of where the root tip was removed. So I extracted the roots, and now the tissue's healed really well. We take a color of the prepared teeth there in the front. So this is called a stump shape because, we have to communicate because the light will pass through and show whatever's underneath through that material. So we have to tell the lab what color we're starting with. So when we give them our end goal, they can make the restorations the right color. This is the shade tab used for the stump shades. And then this is the shade that we picked for the final set of crowns. So this shade guide is for a tooth guide. As you can see, it's labeled right there. That's not, so there's different ones out there. A bisque baked Tryon is an unfired state. These are the actual crowns here. However, they haven't been glazed and they haven't been fined. We're just trying them in, and in this state, we can actually adjust them very easily. They're weak, so you can actually grind them down extremely easily and adjust them. You can use this for verification of the way you set your bite and the appearance and the cosmetics and even the color too. So they can actually stain these to make them darker if they wanted to at this point. I added a little animation here just to show that we're not too pleased with that little black triangle there between the two central incisors, and the gum heights are uneven. However, that was something that the patient didn't want to correct. I'm so used to having this tail in front of my face, so I didn't even realize it was there. Okay, so delivery day, this is the final state of the crowns. They've been glazed, they've been final stained, they're in their hardest form right now. This is actually the EMAX material, the lithium disilicate. So day of delivery, you can see there's a little bit of bleeding from trying to clean up the cement. And a 2-week follow-up, we always bring patients in pretty shortly after to make sure that they're doing well, they're cleaning things well. You can see that black triangle is gone, the gum tissue has crept up into that space, and now we have a good outcome. So basically for this treatment, we did 3 crowns, individual crowns there. We did a 3-unit bridge on that side. So on each end of the bridge, you have the actual teeth underneath. Those are called abutments. And then you have a tooth in the middle in the green there called a pontic. So the tooth in the middle of a bridge, if you had 2 teeth, let's say you had a 4-unit bridge and the 2 teeth in the middle had no teeth underneath, both of those are considered pontics. Okay, so before and after. Unfortunately, this photo was a little blurry, but this is the after shot here. And so now I'm going to go into a different case related to cosmetics. This is a more straightforward case, but sometimes these can be much more difficult. And I'm going to show you kind of a cool way that we did this case. Patient came in for consultation day itself. So we actually scanned her tooth. We actually did a digital mock-up actually, sorry, I applied a composite material to the tooth to make it shaped the right way that we wanted the final tooth to look. We did the preparation and scanned everything the same day, emailed all of this within probably 15 minutes after the patient left to the laboratory, and they started working on it the same day. So we got this back pretty quickly. But there on the left, you can see the preparation. That's the reduction of the tooth. And on the right, you can see my temporary that I made just like right there in the chair. And then here's a photo of the temporary veneer. That's the same day. All this happened in one day once again. Right there in the circle. And then basically behind the scenes, the lab prints out a model from our digital scan. And so you can see that printed. And then you can see the final veneer on the right side and the undersurface of the veneer. That skinny little gray thing that veneer is sitting on is actually called a dye. And they can mill those out, or they can print those out nowadays, which is kind of amazing. It shows us that the margin is correct. Okay, I'm on to the next section, which is the implant and surgery section. And I'm gonna give you a heads up when it's time, when the surgical photos come along, but we have some terminology first. So a dental implant, this is a used implant, but the definition is a biocompatible device used as a bony anchor to support and retain dental prosthetics. So basically, it's exactly what it looks like. It looks like a screw. It's made of a biocompatible material that's not going to cause inflammation. It's unlikely to get rejected by the body. It's actually made based off of the material selection for hip replacements. So a lot of studies were done on that. Dentistry incorporated that too. Nowadays, there's different materials that they started using, including zirconia. So there's a lot of different materials that are being used nowadays. Implant abutments are the little connector pieces that go into the implants, and then it joins the implant to the dental prosthetic. So, and I'll show you how this comes together in a second here. The way that abutment gets screwed in and held within the implant is through a screw. So abutment screws fixate the abutment to the implant. And so kind of the way this goes together here is the abutment gets seated, the screw is usually within it, and then the screw gets tightened. So just like that. And then the crown gets seated on top of the abutment. Cementation usually happens during that phase. Technically, we can't bond the restoration to the abutment. Bonding is usually with natural tooth surfaces. So this is cementation, which is different from adhesion. And here's some more terminology about implant restorations, the kind of the main categories. There's a lot of them out there. An implant crown is a single crown for a single implant. So you can see the model here in the photo has these little pieces embedded within the stone that represent the implants themselves. And it gives us the angle, gives us the height, the position, everything related to where the real implant is located. And then the abutments and the crowns can be designed on top of that. The next implant restoration this is nowadays becoming very common for prosthodontists. It's called a fixed complete denture, but it's more often known as an all-on-4, all-on-6, all-on-X, whatever number of implants are underneath the prosthetic. This is an implant retained bridge. It means it does not come out. It's not like a denture that pops in and out. The patient cannot remove this. It gets screwed into the implants. It's usually, most of the time, on 4 to 6 implants. It's all one solid piece, and the materials can vary from acrylic to zirconia. This image right here is a zirconia prosthetic. You can look up YouTube videos on this. People can hit them with hammers and they don't break. So it's just a really cool kind of an option for patients. And if you saw in the previous photo, there was actually pink material attached to the teeth. So that's going to be one of the main differences compared to this next option, which is called implant crown and bridge. An implant retained bridge, usually on even more implants, 6 to 8 plus implants for this case. And it's called implant crown and bridge because there's no gum tissue incorporated into the prosthetic. So this time when people get teeth, you'll see, I'm going to show you an image. They look more like natural teeth. There's not as much thickness to the material. This option is not available to everyone, and it's actually about twice as much as expensive as the fixed complete denture version. It's a lot more labor intensive, a lot more planning, but it is a good option for certain cases. So, and then one last thing that absolutely you have to know about for implant restorations, the terminology for cone beam computed topography is the special x-ray that you can see in the background there in the image, that giant white object. It spins around just like a panoramic that takes X-rays for like wisdom teeth, but this actually gives us a 3D image, so we can plan our implants. So the definition would be digital volumetric data gathered from the dispersion of X-rays. So a lot of little images taken at the same time, we can actually manipulate that. And I'm going to show you what that looks like here for planning. So before we do implants, we always take a look at a CBCT to make sure that we have the analysis correct for the location of the teeth. And you can see on that jaw right there, on the lower jaw, there's a set of green looking material. That's actually a temporary partial denture that I tried into a patient. And I stuck on something called fiducial markers, which you can see there's like little green bumps projecting outwards and inwards on that denture. Those are called fiducial markers because they have little tags in them that make them show up on X-rays. So we can actually relate the position of this set of teeth that are planned onto our X-ray. So those yellow tubes coming up are the planned orientation for the exit holes for these implants. So we always plan this ahead before we start a case. This screen shows you that same case from a sagittal view from the side, and so you're able to see the thickness of the bone related to each of the planned implants. You can choose the size of the implants based on the needs for the bone and the size of the teeth. So a lot of planning goes into everything before we start our surgeries. Okay, so now we're at the point where we're getting into a surgical slide. There's going to be some maybe like 4 or 5 photos here, I think, that have quite a bit of blood, and it's, once again, it's surgery. So if that's something you don't want to see, I'll tell you when I'm done with the slide, and then you can watch again, but you can listen to what I'm saying. So, okay, I'm starting the slide, just letting you know. That's a heads up. By the way, the cat is related because, you know, scary cat, right? Okay, so that's my cat. But, okay, so now we're into the maxillary all-in-4 and mandibular implant crown and bridge case. This right here that you're seeing in the image is the mandibular ridge. So it's the lower jaw. Patient was completely edentulous, had no teeth. We planned the case based on a set of design teeth, just like the previous slides. We knew exactly where we were going to place the implants related to the future teeth. So we knew the plan, we knew where the future teeth would be, and the guide was based off of that. This guide will tell us, it gives us only one option when we place the implants, and it's the planned option that we did digitally. So the implants can't go anywhere else. Third image here, the implants have been placed. It was six different implants. This image that just showed up in the bottom right side is, it's a material called PMMA, or polymethyl methacrylate, which is like a really hard resin or plastic, and it's long-term temporaries. So I had a lab fabricate, and I think they printed this one, or they milled this one out of a giant block of material, and they hollowed out the under surfaces of all the teeth so that we could actually attach them to the implants the same day as the surgery. So the patient's going to leave here with teeth, even though, you know, the implants have just been placed. This is just not attached yet in this image here that says milled provisional shells. That's just sitting on top. I was just getting a picture. And so that's the same exact temporary prosthetic right there. And then this image is the maxillary surgical stent. It's not a surgical guide. A stent doesn't tell us exactly where the implants are going to go, but it gives us an idea about the emergence of where the exit holes will come out of. The upper set of teeth are planned to be an all-in-4, which is that fixed complete denture. So it's a lot thicker, and the placement of the implants is not as fine-tuned as the lower set of teeth. Lower set of teeth is not going to have any kink, and the implants have to go directly where the teeth are. For an all-in-4 prosthetic, there's gum in the prosthetic, and so the exit holes are a little more lenient. There's obviously some mechanical rules that we have to follow in prosthodontics for that. But that's why, for this case, we used a surgical stent instead of a surgical guide. So there's a lot of different markers on that that give us a lot of clues on where we need to go. And then you can see in that top photo, the lower set of shells have actually been attached to the implants, and now they're... and then for the upper teeth, unfortunately, I don't have a photo of this case. It starts off as an immediate denture, which is basically just a denture ready the day of the surgery, and it gets attached to the implants, and all the material gets reduced down to what's the minimum amount that we need, and it turns into like what looks like a horseshoe, which I'll show you in a few slides here. and it gets screwed into the implants and basically acts as like a natural set of teeth. Patients have to be very gentle during the healing stage, but after that, they're fixed and they're great. So I'm going to show you a little bit about kind of that lower set of teeth that we just did. This is the same case. When we take an impression of those temporaries, when I take those temporaries out and I take an impression of those implants, you see an image like in the top left. So I poured this up and you have a blue material that's like rubbery. And then we take that rubbery stuff off. So soft tissue is removed. Then I get the actual set of temporaries and put them onto the model or the cast, screw them in, and then I inject a new material for gum tissue underneath those temporaries. Because if I don't do this, the second I take those temporaries out of the mouth, gum tissue collapses. And actually what happens is that our final set of crowns can't be contoured the same way. So we have to capture those temporaries this way, and you'll see what happens next, which is actually we take those temporaries off of the model. And now you can see that in the top left, we have all the indentations of the temporary crowns that we spent so much time on contouring the gum tissue with for good cosmetic appearance. We add an acrylic material, something that doesn't shrink very much. So there's a few different materials out there. GC pattern resin is a big one that we use. So that red stuff that you see there is injected in with these tall little pieces called impression copings. And that's what we insert into the implants to capture their positioning. For this case, 3 different bridges. So that's why there's 3 different segments in that bottom photo based on the planned locations of the bridges. We then take that, we insert it into the mouth. Those little pin becomes fixated. From here, we take an impression on top of this and it gets removed. And you can see those red little pieces are actually incorporated into the impression itself. And now we have a very accurate model of the implant locations along with the shape of the actual gum tissue. And the lab can fabricate us a final set of teeth that have the same shape of gum tissue, which is obviously what we want. We want things in prosthodontics to be very controlled. So if we don't do this step, we lose a lot of that information. Okay, and then from there, the lab, or in this case, I actually poured this model up. That pink stuff is the same thing as the blue stuff you saw earlier. It's soft and rubbery. And for this case, I used the gold hue custom abutment, which means that it was these silver little pieces that get screwed into the implants are anodized to become gold, because gold does not show through gum tissue as easily. So if you have a titanium colored abutment and you put a crown on top and the gum tissue is very thin, you can actually see. So to hide that, there's different techniques. One of them is to color the titanium abutments and make it look gold through anodization. So that's a technique that was used here. I took like a really fancy photo for my Instagram. So yeah, shameless plug, right? Okay. So, and then for an implant crown and bridge case, it's 2 arches. So the top and the bottom are only implants. And I think for the top, it was like 8 implants and the bottom was 6 implants. And so cases like this take a lot of planning, especially because the patient already had a lot of existing implants. This is actually a direction that we're going in terms of dentistry. You guys will probably experience this even more than I am right now, where patient comes in, so the dentist takes it out and places 1 implant. They come back in 3 months later, they have another tooth that needs to goes in, and it repeats and repeats and repeats. And now you end up with a hodgepodge out, kind of a clear goal in mind, because the location of implants really drastically impacted this case specifically. So I had to take certain implants out and put new ones in, because the planning 20 years ago, of course, wasn't foreseeing these issues that she was going to have in the future. So when it comes to implant dentistry, it's great, but you really have to look at the long-term approach, especially when a patient has a lot of teeth that are already in a compromised state. Okay, so I'm going to go through a whole series of images now that are related to surgery. And I realized I didn't tell you guys I was past the surgical slide, so I hope everybody was watching that. But I'm going to go through another series of this really interesting case. It's a lot more surgery-ish looking, you'll see. So once again, if you're squeamish at all, like my cat is at the veterinarian, then you may want to just listen to the next part. Okay, so this case is an all-on-5 case. This is the type of case that has the pink incorporated into the prosthetic. So looking at the gum tissue, that's honestly not something normal that you see from this type of prosthetic. I've seen thousands of these in person. Red gum tissue like that is never a good sign. And it's actually kind of more of a purplish color. When it comes to something like this, you don't always know what's going on. So it's always recommended that we take x-rays of these implants like periodically as needed. It depends on like if the patient's taking care of their prosthetics or not. In this case, I knew what was going to happen because I saw the x-rays ahead of time. So I called the oral surgeon up for this case. I didn't do this surgery. It's a little bit beyond my skills, and you'll see why. So once again, the terminology, just to orient yourself on what's going on in this picture. Anterior is pointing up, that's towards the nose, like the outside of the mouth. Posterior is towards the back, towards the throat. It gets a little bit confusing in terms of location of things because of how close up these images are. But I'm going to point out to you that that's something you should never see with an implant. You should never see micro threads, which are the thinner threads at the very I guess in this image at the bottom of that yellow outline. And then you can see the macro threads that are really big. Micro threads sometimes get a little exposed, but the macro threads, when they become exposed, can be a big issue because food and other things can get stuck, and you continue to lose additional bone throughout the years because of localized inflammation. Okay, so 2 failing implants in the back, and now we don't have enough bone that we can place a new regular implant into these positions. So we had to come up with another plan, which is something called a zygomatic implant placement. Zygomatic implants, I'll explain in a second, but I'm going to show you first what this location is. So to kind of orient you, the lateral wall of the maxillary sinus is right here. So you have these air spaces that like during the winter time, or sorry, actually during like the spring, you'll get pressure in your sinuses. So those are air spaces right up here. Those are the main ones that get that pressure. They're called the maxillary sinuses. So this is actually the outside wall of the sinus. We've lifted up the gum tissue, pulled the cheek back, and you can see there's a hole that we've cut out to see where the location of the sinus is. There's a membrane that coats the inside of all sinuses, and the specific one for the maxillary sinus is called the Schneiderian membrane. And so it's like a rubbery material. It's easy to break, so you have to be very gentle with it. It's very delicate. So we lift that membrane up, insert a zygomatic implant, and then we go from there. I'm going to show you what a zygomatic implant is in the next slide, so you have an appreciation for what this actually is, because it's very different from a regular implant. So zygomatic implants are cheekbone implants. Zygomatic arches are the cheekbones. Zygomatic process, so the cheekbone implant actually goes into the mouth, goes through the maxilla, and it comes into the cheekbone, because we do these cases when there's not enough bone in the maxilla to hold an implant, and we need more support in the back for the prosthetic. So sometimes the only bone available are unfortunately the cheekbones. In some cases, people don't even have cheekbones. They have just like a tiny little thing right here that's not even good enough for a zygomatic implant. Zygomatic implants are very different from regular implants. You can see in the image on the left, there's a company called Southern Implants that makes an implant that has like a smooth section in the middle, because a lot of times you go through the sinus, and having a smooth section in the middle prevents things from clumping up on it. The one on the right is kind of the more traditional type of zygomatic implant. They're anywhere from like 35 millimeters up to like 60 millimeters. They can be huge. And it all depends on the case. So we plan everything once again with the CBCT. That implant on the right is more of the traditional size, which is anywhere from 7.5 millimeters, like really small, up to 18 millimeters, which is pretty big for a regular implant, but we need them sometimes. So zygomatic implants are like huge compared to regular implants. So these surgeries are very intense, and usually prosthodontists, our role is to make sure that the placement of those implants is usable for our prosthetics. So we're there for the surgeries to make sure that the outcome is going to be good for the patient. Buccal fat pad. Okay. Something that I honestly did not know until residency was that everybody has a little clump of fat in their cheek. Prepare for it at all. I studied the Kaplan book, and the Kaplan questions for PAT were the easiest PAT questions in existence. I could have thought of harder questions easily. And so I went into the exam thinking like, oh, PAT is going to be so easy. And then I sat down, and instead of having a shape that's like, like that, it's like crazy looking, and then the angles are probably within like 0.1 degree difference, and like highly recommend, just for fun, start working on PAT no matter where you're at in your studying. Like, think of it as like puzzles. Don't wait 2 weeks before the exam to look at PAT questions and then assume it's going to be that easy, because it's not. Like, that's an important section.
So the next question is, when did you start shadowing and volunteering, like with dentists?
Okay, so my mom's a general dentist, so I've I was kind of in and out just randomly throughout my entire life. I shadowed an orthodontist for a summer in high school, or no, it may have been in college. And then I was at my mom's. She had her own office, so I was there pretty often, kind of just throughout my entire life. So my shadowing experience was largely related to just those two dentists. I shadowed an oral surgeon actually for a short time too, and I mean all the experience is great. And when it comes to applications, of course, it's very important. So shadowing hours right now can be tough. I think a lot of dentists are probably stressed out and they just don't want to be seen as like that dentist that has like all these people in their office because it scares patients. In some cases, some patients don't care. They don't even think COVID's real. But then there's other patients that are just absolutely scared. So you have to be careful as a dentist. So it's understandable if it's hard to find shadowing hours right now. But opportunities like this are really important. And then making sure that you're kind of on track in terms of hopefully being able to do some shadowing in the future, or working at a dental office is another option. Even if it's part-time, just having that experience alone will also give you a lot of kind of heads up on what dentistry is actually like. So, I mean, there's people that get into dental school and they're shocked by what dentistry is, and so you should definitely see what dentistry actually is before applying.
All right, unfortunately, that's all the time we have today. Dr. Prompton, I'd like to thank you one more time for your insight today and for presenting all those cases. It was a very insightful presentation. And yeah, that's all the time we have for today. And for everyone else, for Pre-Dental Universe members, we'll be posting the link to the quiz in the group me. So be on the lookout for that.
Yeah, also make sure to, follow Dr. Prompton's Instagram handles right here.
Yeah, please do.
Thank you everyone for attending tonight's session. We can't thank Dr. Prompton enough, and I'm so sorry about any connectivity issues. We'll make sure that doesn't happen next time.
Thank you, everyone. And yeah, it was very, very exciting and fun to be able to talk to you guys. And hopefully we'll do it again sometime soon.
Yes, thank you so much.
Thank you, Dr. Prompton.
I hope you have a great evening.
Thank you.
Thank you.
Have a good one.